Hi everyone, and welcome to Anesthesia Coffee Break. I'm here with Archit, who is we're gonna discuss West Zones and a few other things. How's it going?
Hey, Lahira. Hi, everyone. It's been a little bit of a hiatus, but we're back. A few things have happened, so congrats to all those that have passed their primaries. Commiserations to those that didn't. I'm sure you guys will get through the next time. And offers have also come out for the program for next year. So congratulations on those now future trainees that are going to be ongoing and starting this process next year.
Hey, well done everyone. And I think like me and Stan have discussed in the past, like just this exam is brutal. A lot of 60% of people pass. So just because you don't succeed this time, the stats are that once you sit your second, third, and fourth time, it gets close to 99%. Now, obviously, that's brutal. It's a lot of exam prep, and you definitely want to try and get this done on the first or second go. But I think there's far more acceptance that there's so much material to cover that sometimes it takes a couple of goes, and that's completely fine. Hey, let's get started. So, what are these mysterious things called West Zones? That's the whole point.
Yeah. West zones are these zones in the lung. They're not actual proper zones per se, like anatomical zones, but they're regions that are divided according to the sort of interplay between the alveolar pressure, the pulmonary artery pressure, the pulmonary venous pressure. So we'll chat about this in a little bit, and it's through experimentation through West, who is, I think, a respiratory physiologist, and they found this difference in the vertical pleural gradient, and because of that, he actually divided these things into three discrete areas.
Beautiful. And just to clarify, so the West Zones is all about how blood flows, in the lung. So it's about blood flow. It's not about ventilation. It's not about intrapleural pressures necessarily. It's about the vertical gradient of perfusion. Now, if you think about most organ systems, Archit, so if you think of what are the factors that affect blood flow in most to most organs?
Yeah, so it's pressure from a high area to a pressure to a low area, and
Perfect.
then any resistance in between that's encountered.
Beautiful. So those are two separate things now. Great. So we've got arterial pressure is the forward pressure, venous pressure is the back pressure, and then that difference gives you how much force you got. And then using some variations of Ohm's law, V equals IR, where V is the pressure differential, and I is in electricity it's the current, R is resistance. You can calculate I is V over R, or the pressure difference. V, P arterial, take away P pressure venous over resistance. Now, this is just a really crude mathematical model because blood flow is pulsatile and there's all these other factors. But just know that that's the standard for most, if you take any length of artery and vein or whatever, it's the pressure differential. Now, you mentioned a really cool thing there, which is any external pressure. So imagine you've got the heart and the coronary arteries. When the heart muscle contracts, now you've got a thing where there's pressure. The back pressure could be from the walls themselves.
Yeah.
And we call that a Starling resistor, because now you don't have just the venous pressure causing back pressure. Your determinant or the main back pressure might be something external, something outside and putting pressure on the capillaries or the veins or the arteries. So this happens in the kidneys, it happens in the heart, it happens in the brain. It also happens in the capillary beds, especially if there's interstitial edema and stuff. So Starling resistors, very important. Arteriovenous pressure difference, very important. And West Zones talk about how all of these things happen in the lungs from top to bottom, and that's how blood flow is determined.
Yeah.
So that's probably a good place to go into the different zones. There's actually 4 West Zones. 3 probably are in normal state, and then the 4th zone in situations where you might have some pathophysiology occurring. So tell us about West Zone 1, Archie.
Yeah, so West Zone 1 is where your alveolar pressure is higher than your arterial or venous pressure, as far as I'm aware. So in West Zone 1, you've got, as I said, the alveolar pressure itself within the alveolar exceeds that pressure, which then exerts that Starling resistor principle. So there's little or reduced gas exchange that takes place in this area, because if you think about it, there's not as much blood flow that can pass through. So in this instance, as we said, blood flow is actually limited and probably related very much to systolic, and it's cyclical, and it's dependent on the phase of the respiratory cycle.
Yep. So let's keep it like a pure definition then would be that P alveolar pressure is greater than P arterial pressure, which is greater than P venous.
Yeah.
Which means that, let's say technically, if alveolar pressure is always higher than arterial pressure, then there's no flow. Like literally, you've got so much pressure difference, or the alveolus has so much pressure, or the arterioles have so little pressure that there's no blood going. It is true to say that blood flow is cyclical, so there's probably points in the cardiac cycle where there might these West Zone 1s might turn into West Zone 2. That's true, but let's say West Zone 1 is where there's no flow. There's no flow because arterial pressure cannot overcome alveolar pressure. Now, can you think of some examples where either the arterial pressure is low or the alveolar pressure is really high?
Yeah, so I guess we would, during anesthesia, we'd be inducing something like this by when we turn up our PEEP. So obviously with our PEEP, you're having that increased alveolar pressure, which then again leads to that blood not being able to flow through. That would be the alveolar side.
And let's clarify. So you mentioned PEEP, which is a great example of a stable high pressure. Because imagine the worst lung disease and you got to get your PEEP up to 5, 10, 15, 20 in worst kind of ARDS situations. Great. That's bad. But you might also have just really restrictive lung disease, obstructive lung disease, and you have to generate really high positive pressure. So it might be PEEP, but it might also be high positive pressure ventilation. So any high alveolar pressure totally will cause a West Zone 1. How about low P arterial?
So low P arterial, I guess that you're thinking about areas and states of shock or hypovolemia. So when there's less blood flow, obviously intuitively there's actually less amount of that difference that we're talking about between the arterial and the venous. So there's a tendency to collapse of that blood vessel.
Yeah, and again, just keeping it to the formula. If I was just to say, if I have less blood, or if I have blood loss or less volume in the intravascular space, my pressure will decrease. The ultimate determinant of blood pressure is volume in the system and compliance of the arterial tree. So I've got a hemorrhage situation, I've got severe dehydration, whatever else. Maybe the patient is now standing up versus supine, so I've got more of a gradient, a hydrostatic pressure gradient, whatever it is. Arterial pressure in the lungs is low. That will cause it. So I really care about. Now, why do I care about this? This means that there's another term for Zone 1 where you have ventilation but no perfusion.
Yeah, like dead space.
That's it. Yeah, great. So Zone 1 is dead space, and dead space means that now when it means that I've got compromised VQ mismatch throughout the tree, throughout the lungs. But effectively, how does this? When I look at this, I go, okay, this is not optimal because I've got something happening. But dead space itself just means that if I look at my end-tidal CO2, it will be really different from my PA CO2. So imagine my end-tidal CO2 is something like 30, and I think I'm ventilating this patient adequately. The PA CO2 might actually be much higher because I've got dead space. Dead space contributes to a real gap between end-tidal CO2 and PA CO2. And so I've really got to think about that. Imagine a multi-trauma where, so clinical context, multi-trauma, lots of blood loss, and they've also got head trauma. In head trauma, if we're worried about a tight brain or increased ICP, I need to make sure my PA CO2 is low normal, let's say 30. So I might have to ventilate this patient more to make the end-tidal CO2 less. So I'd be checking ABGs, checking my blood gases, and try to find a correlation between the end-tidal CO2 and then aiming for certain values. And as I resuscitate the patient, the numbers between end-tidal CO2 and PA CO2 get closer and more, just narrower. And that way I can, treat effectively this tight brain. Yeah. Good. So that's West Zone 1. What do you think about West Zone 2? What's that about?
So West Zone 2, as per definition, is where the arterial pressure is higher than the alveolar and venous, where it again changes within the respiratory cycle. But in our definition that we're talking about, so it's the pressure of the PA is greater than the pressure of the alveolar, which is greater than the pressure of the venous system.
Great. So that's right. So your determinant of blood flow is P arterial versus P alveolar, and P venous doesn't have anything to do with this really. And you find that as you progress down the lung, your blood flow increases. So if you imagine a constant ventilatory state, your average alveolar pressure is pretty constant, but as you move down the lung, the arterial pressure increases because that's due to the hydrostatic pressure of a vertical lung, and so you'll get increased blood flow. This is the example of a Starling resistor where the wall pressure is what determines the backflow, not the venous pressure. So there you go. And we'll put up a diagram in a second as well. In fact, why don't I put up that diagram now, because it kind of helps to demonstrate this principle. Beautiful. I think we can all see that there. So zone 1, you've got complete collapse, high alveolar pressures, which is P big A, and there's no blood flow because P arterial just isn't high enough. By the way, this diagram is directly from West's, I think 7th edition. And we just talked about number 2, where now we've got a Starling resistor. Let's say alveolar pressure is pretty constant on average, but you get blood flow here increasing because your arterial pressure increases as you progress down the lung. That's due to hydrostatic pressure, which is the effect of gravity causing a higher pressure on this column of fluid. Let's talk about this West Zone 3. What do you think that's about?
So West Zone 3, where your arterial and venous pressure is greater than your alveolar pressure. So as we can see in there, we've got our PA is greater than the PV is greater than the alveolar pressure.
Fantastic. This is the normal state of most blood vessels in the body, where you just have an artery and a vein, and the difference in pressure is your blood flow. You can see that as you progress down zone 3, you also get a slight increase in blood flow. And again, that's because of hydrostatic pressure gradients, that the P arterial is increasing more than your pressure in the venous system. And also, yeah, that's right. So this is interesting, right? So there's a concept called recruitment and distension. Now, distension is where when you get more pressure in the arterial system, the vessels distend and you actually get less resistance. So that increased blood flow is a lot due to distension of your vessels, decreasing resistance, but now they're a wider caliber and you get more blood flow. You also have this concept called recruitment. Recruitment is the opening of previously closed vessels due to getting to a certain cap pressure. As soon as it gets to that pressure, extra vessels open, so now you have overall less resistance in your system, therefore more flow. So zone 3 increases flow due to pressure, but that pressure causes this concept called recruitment and distension. That's West Zone 3.
Yeah.
What do you make of West Zone 4?
Yeah, West Zone 4 has always been a confusing one for me.
Okay.
But yeah, as per this definition, for those that are listening, it's the pressure of the pulmonary arterial system is greater than the pressure of the interstitial fluid around that area is greater than the pressure of the pulmonary venous system, which is greater than the alveolar pressure. Yeah,
great. So what you find is, everyone just check out on YouTube, as we'll send this podcast video to YouTube. You've got all these numbers, PPA greater than P interstitial fluid, greater than PPV, greater than P big A, which is alveolar. Just know that it's just the first two that matter. They're just demonstrating that all of these things are greater than the last things that we've mentioned. So in this zone, arterial pressure is greater than interstitial pressure, which is good because you're getting blood flow. But down the lung, interstitial pressure now increases for some reason. And this is often due to pathophysiology, like maybe there's some kind of interstitial edema and that's increasing. So this is not a good state because your blood flow in the lung shouldn't be determined by all this excess fluid that's causing pressure. And this is again an example of a Starling resistor then, because you've got some external pressure trying to compress these beautiful vessels that are recruited and distended. So that's that. So zone 4 apparently occurs at low lung volumes. Narrow extraalveolar vessels means increased resistance to flow as well.
Mm.
Beautiful. And here we go. That's Respiratory Failure, John B. West, page 48, chapter 4, 9th edition. Just for everyone to know. Is there anything else to add about that? Oh, shit.
I don't think so. I think importantly, I guess in going back to zone 1, which is sort of predominantly the one that we talk about, as we said, it does contribute a lot to that dead space where you'd think that there's no ventilation that happens, but there's always little bits, what we call corner vessels, which are sort of the capillaries that are around, which do contribute a little bit to that ventilation. So it's not necessarily zero everywhere. When you turn up that peak, there is some ventilation and going on. So I think that's something I found a little bit interesting to think about, where even if you do have that, what we talked about, the principle of decreased ventilation, there is still ventilation occurring at those areas.
And it is good what you said, like, even though the diagram shows at the top you got 1 and at the bottom, and then 2, 3, 4 down to the bottom of the lungs, it is, it's a concept, because ventilation is cyclical and blood pressure might change in certain areas for certain reasons. So roughly speaking, at the independent of the top portion of the lung, it's mainly going to be West Zone 1. That's where it will exist mainly, but this can change through things. So now I guess the next thing is, this is a vertical, like this is a erect patient. What happens when you have a patient lying supine?
Yeah, so when you have a patient lying supine, your hydrostatic pressure that we talked about is actually changed, where the blood flow is now on the, I guess, posterior aspects of the lung itself.
So let's say the dependent portion.
The dependent portion of the lungs, whereby your sort of air sort of goes more towards your independent portion of the lung. Is that correct?
Let's not worry about that. Let's just talk about it as in you just flip this diagram. You make the lung horizontal, and now your West Zone 1 is going to exist mainly in the anterior part of the lung. The top of the lung, and it just progresses down. And same, like, you could be asked all these kind of applied questions, like, oh, how about a patient in the prone position? Same thing. Now the anterior is where is the dependent part. So West 1 is going to be in the posterior part of the lung.
Yeah, exactly.
Imagine all the different complications. I think that's all we need to cover with that. Look, let's call it at that. That's West Zones. Pretty well explained. I think the best thing to do is just know what the purpose is. This is talking about how blood flow changes. What are the determinants of blood flow as you progress through different zones of the lung? And the fact that there might be when you try to memorize these diagrams, just look at West and try to memorize which one is greater than which one, because then you know what the determinants are. So P alveolar greater than P arterial, that's West Zone 1. P arterial greater than P alveolar, that's West Zone 2, so on and so forth. So just being able to draw that diagram roughly and just write that little equation, I think is a really good step to understanding what happens. Thanks very much, everyone, for listening. So next episode, we're going to cover things like shunt and the shunt equation and venous admixture. And we'll see you again next time. Please share with anyone who might be interested. This is Anesthesia Coffee Break.
See you, everyone.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.